السلام عليكم ورحمة الله وبركاته. My name is Dr. Wujdan Basfar. I'm an assistant professor and consultant of pediatric complex care at King Abdulaziz University. Today we're going to talk about when nothing's wrong but it hurts, pediatric functional GI disorders. This lecture is a part of a series of e-learning modules. This modules includes other educational activities that you're expected to complete as well. Learning outcomes. By the end of this module, you should be able to identify the typical clinical presentation and natural history of common pediatric functional GI disorders, differentiate functional from organic causes of chronic GI symptoms in children, and recognizing red flags, develop a basic age-appropriate management plan for functional GI disorders, and demonstrate effective communication of a functional GI disorders diagnosis to caregivers and children. Please note that not all of those learning outcomes will be covered during this presentation. Some of them will be addressed by other educational activities or self-directed learning. So in this presentation, we'll start by giving an overview of functional GI disorders in general, so definition, pathophysiology, management and diagnosis, and then we'll focus on 4 of the most common functional GI disorders briefly. So GI disorders in children are either organic or functional. What are the differences between them? The only difference, the organic, there is underlying tissue damage, while in the functional, there isn't any organic tissue damage. For both group of disorders, the children are experiencing symptoms, and the symptoms may have affected their quality of life, and they're suffering from the symptoms. But the only difference is the underlying tissue damage. In this presentation, we're going to focus on the functional GI disorders. From the name functional, the abnormality in the function, the normal daily activity of the gut, like absorption, motility, secretion, and brain control all of the gut function. So what is functional GI disorder? Is a group of disorders characterized by chronic or recurrent GI symptoms, not explained by any structural or biochemical abnormalities. How common they are? They're very common worldwide, around 10 to 27% in children and adolescents, and around 27 to 40% in infants and toddlers. In a recent Saudi study, prevalence study, it shows that almost half of infants and toddlers are experiencing functional GI disorder in Saudi Arabia. This figure is from the recent Saudi study, and it shows that functional constipation is the most common functional GI disorders, followed by regurgitation in the infant and toddler age group. It also shows that females are more affected in these disorders than males, although in this particular study, it wasn't statistically significant difference. Please pause the video and try to answer this question. How often functional GI disorders account for visit in GI pediatric clinic? 30%, 50%, 1%, or 10%? Why we need to know about this? Not only because these disorders are very common, but also it accounts for 50% of GI pediatric visit. Their symptoms are real, negatively impacting the child and family life, and the economic burden on the healthcare system is huge. And also it's functional, but that doesn't mean it's fake. Pathophysiology, it's still poorly understood, but we know that it's multifactorial, and we know that due to disruption in the gut and brain communication. So there are many factors leading to these disorders. Genes, so children who has family history of functional GI disorder are more likely to develop it. Early life event like infection or stressor can affect the way that gut and brain develop and communicate. Psychosocial factors such as depression and anxiety, Poor coping skills can worsen those symptoms and affect the way the gut works. Also, disruption in gut microbes contribute to the pathophysiology. All of those factors works together, causing visceral hypersensitivity, central sensitization, dysregulation of the neuroimmune system, disruption of the gut-brain axis, and eventually lead to development of these disorders. We can use the smoke detector analogy just to make you understand the mechanism better or remember the mechanism, and you can use it maybe if you explain to a family about these disorders. So the smoke detector, when you put it in your house, its job is to alarm you if there is a fire. But what if the smoke detector goes off when you're doing your daily activity of cooking or even accidentally burned a toast? So it goes off. It's not because the detector is not working, but it's oversensitive to any smoke or steam. Same thing with those functional GI disorders. The gut is happy, there is no disease, it's healthy, it's doing their daily activity, but for some reason, the brain is oversensitive and is alarmed when there is no a disease, so it keeps sending pain signaling to the body to alarm the body. I hope it's clear. Question 2, which of the following is red flag symptoms in a child with GI complaint? Intermittent abdominal pain, weight loss, pain relief by bowel movements, or occasional constipation? Please pause the video and take a moment to answer this. Let's talk red flags. When to think beyond functional GI disorders. There are systemic, GI-related, or family-related red flags. Very important to know all of them and to ask about them in the history to rule out organic causes. The systemic, unexplained weight loss, poor growth, very important in pediatric, delayed puberty, unexplained fever, pallor, joint pain. The GI-related, GI bleeding, not functional, bilious vomiting, nocturnal symptoms, or symptoms that awaken the child up at night, pedinophagia, localized abdominal pain away from the umbilicus, family history of inflammatory bowel disease, celiac disease, or peptic ulcers. Diagnosis. Diagnosis is very challenging in the functional GI disorder. A lot of physicians do a lot of investigations. So that's why you need to have the knowledge and the awareness about the functional GI disorder, because it's diagnosed usually clinical by doing very good history, by taking very good history and doing very good physical examination. Since there is no abnormality usually in the tissue or the anatomy or labs or imaging or even scope, so it's diagnosed, but only clinical. There is actually a diagnostic criteria called ROM4, that is symptoms-based to help us make the diagnosis. So diagnosis is based on confidence, not exclusion. You can do some investigation if you would like to rule out other causes, but you do not have to. Management. So management of functional GI disorders in children, like any management, it starts with accurate diagnosis. You have to take full history, try to ask all of the red flags, try to identify the extent of the functional impairment, because it will help you in planning management later on, and then do a full physical examination. You can do some investigation if needed, but it's not necessarily, as we said. After making an accurate diagnosis, very important to explain this vague disorder to family. So reassure them it's not serious, validate their symptoms, I believe you, it's real, and educate them with empathy. If you fail to do this, no matter how good your management plan that you give the patient, they will keep coming back to the hospital, they will keep coming back to the emergency room or other specialist clinic. So it should start here. And then you can make individualized multimodal treatment plan. So there are behavioral strategies that we can use, dietary modification or medical therapies if needed. And the focus or the goal in the management of any functional disorder is to improve function, but not to relieve every single symptoms. We're going to talk quickly about them. So behavioral strategy, we have the cognitive behavioral therapy, very effective. Relaxation technique, biofeedback, dietary modification. You need to identify a trigger from diet. There are many dietary intervention or modification we can do. There are not a lot of evidence for most of them, but there are some evidence and it's worth the trial. We can use medical therapies, and it's usually symptoms directed, whether to work on the motility or acid secretion, or rebalance the gut flora. It depends on the main symptoms in the patient. So sometimes we use laxative. We even sometimes use SSRI in some cases. Also fibers, peppermint oil, probiotic has some evidence. After you do that, you need to follow up with the patient and monitor their symptoms if there is any progression of symptoms or development of new symptoms that may be red flag and lead you to do further investigation. Functional GI disorders by age. In pediatric, we typically divide children according to their age to different age group. We have the infancy in the first year of life, toddlers 1 to 3 years of age, preschooler 3 to 5 years of age, and then the school-aged children until 12 to 18 are the adolescent. Well, in this context, different age group has different type and presentation of the disorder. So in the infancy, gastroesophageal reflux, infant colic, and dyschezia is very common. In the toddler age, toddler's diarrhea, preschooler, functional constipation. And then in the school age, functional abdominal pain, cyclic vomiting syndrome. In the adolescent is irritable bowel syndrome and abdominal migraine. Some of these conditions overlap between age group, like the functional constipation and the functional abdominal pain. Now let's talk about the 4 of the most common functional GI disorders. We'll start to talk about gastroesophageal reflux. True or false, spitting up after every feed in a 3-month-old baby is always a sign of a disease. So gastroesophageal reflux is effortless retrograde movement of gastric content in the esophagus and then comes up in the mouth or nose. Rumford define it as regurgitation 2 or more times per day for 3 or more weeks in an otherwise healthy, thriving infant. No reaching hematoemesis, aspiration, or apnea, or failure to thrive, or feeding refusal. Very important. So gastroesophageal reflux is very common. There are physiological or pathological. Physiological is the most common. And it's important to know when it becomes pathological and become a disease. So as we said, it's very common. It begins at 4 months of age, and it's often due to immature lower esophageal reflux, liquid diet, supine position, short and narrow esophagus, small and non-compliant stomach. And tend to improve around 6 to 8 months of age once they start to eat more solid and they're able to sit, and resolve by itself by 1 year of age after even their anatomy start to develop. But in the physiological gastroesophageal reflux, there shouldn't be any growth issue, no respiratory complications, or any symptoms of esophagitis. Because if there is any one of these, it become a disease. Gastroesophageal reflux, it become a disease that may need treatment. So what are those red flags that point you to GERD? Poor weight gain, projectile or bilious vomiting, blood in vomit or stool, feeding refusal, cough, wheezing, or apnea. In management, it follows the same principles as the other functional GI disorders, so educate, reassure, validate. There are some advices that we can give to parent with a child who has physiological gastroesophageal reflux, like keep them upright after feeds, give them small frequent feeds. Sometimes we add the milk thickener. And as we said, it resolved by 1 year of age. When it become a disease, when there is a growth issue or there is a symptoms of esophagitis or some respiratory complication, you have to treat. Well, we tend to treat by the PPI. Sometimes we do further workup to rule out underlying anatomical causes. And if you don't have enough experience or it becomes complicated, you can always refer to pediatric gastroenterologist. Functional constipation. Assalamu alaikum. This is part 2 of functional GI disorders lecture. In part 1, we discussed functional GI disorders in general, covering its definition, pathophysiology, diagnosis, and overall management. We then began reviewing the most common functional GI disorders, starting with gastroesophageal reflux. Now we will continue with looking at the next most common functional GI disorders, that is functional constipation. True or false? Fecal incontinence can be a symptom of functional constipation. Persistent constipation for 1 month is always a red flag in children. Please pause the video and try to answer this. Functional constipation definition by room 4 criteria for 4 or older, for 4 years of age or older, at least to have 2 of the following for 1 month or more. 2 or less defecations per week, 1 or more episode of fecal incontinence per week, large stools that may clog the toilet, painful or hard bowel movements, retentive posturing like the one in the picture here, stiff and crossed leg or extended leg, large fecal mass in rectum on exam. Well, what happens in functional constipation is a vicious cycle. Start with the child doesn't want to go to the bathroom to defecate, whether because they're afraid to go there or because they're playing and don't want to go to the bathroom right now, or because they're in the school and doesn't want to use public bathroom. So they withheld and the stool. So what happens in the colon, it will overabsorb the water, and then the stool with time will become harder and bigger, and the colon will be over distended, so it won't be able to contract efficiently. So when they eventually go to the bathroom to defecate, it will be a painful experience. So the next time they feel like they want to defecate, they will postpone going to the bathroom, and it's a vicious cycle. It goes on. So that's what happened in functional constipation in children. It's interesting that sometimes they do not present with constipation. They will come with abdominal pain, anorexia, or enuresis. And sometimes I've seen patient getting admitted to the hospital, a lot of investigations done because of the abdominal pain. It turns out to be just functional constipation with a lot of stool infection. In physical exam, you may feel the stool in the abdomen. So the diagnosis, as I said, is clinical. In the right, you can see the Bristol stool chart, which is a chart that divides stool according to their consistency. Is very important or useful tool for diagnosing constipation. I often use it in the clinic because not everybody can communicate their bowel movement, especially children, to their physician. So if here in type 1 and 2 is consistent with constipation, you can just show it the child, it's with picture, so they can point to the picture. So again, diagnosis is clinical by taking history and doing exam. We rarely use any investigation. Some physicians still do some x-rays, but it's not necessarily for diagnosis. Management, we'll talk more about it in the following slide, but essentially it's disimpaction and maintenance by laxative. Also, there are some behavioral strategies that we can give to the patient and diet change. So this is from a published Saudi expert consensus on the management of functional constipation in pediatric. So it starts, as we said before, it's always start by accurate diagnosis, making sure that there is no any red flags. If there is a red flag, it's a different pathway. It's not functional constipation. And then educate, reassure, and validate the symptoms. If there is a fecal impaction, you have to do disimpaction using the oral polyethylene glycol or lactulose. If there is, if it was effective, then you use maintenance therapy for 6 months with doing some dietary changes, mainly increasing fibers and water intake, and some behavioral strategies such as scheduled bathroom visit, use some stool or chair under your feet when you're defecating, etc. So it follows the same pathway. If they don't have impaction, we go right away to maintenance therapy with dietary change and behavioral therapy. And if it's effective, you stop the laxative at that time and you follow up the patient. If the maintenance therapy was not effective, or if the patient has impaction and you fail to disimpact, you always refer to specialist at that point. Now let's talk about functional abdominal pain. Abdominal pain complaint in children is very common, and most of it is not serious, and it's functional abdominal pain. Abdominal pain involves functional dyspepsia, irritable bowel syndrome, abdominal migraine, functional abdominal pain not otherwise specified. We're going to talk about these two in this presentation. Let's start with irritable bowel syndrome. So true or false, functional abdominal pain not otherwise specified and irritable bowel syndrome are the same condition. IBS defined according to Rome 4, recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with 2 or more of the following: related to defecation, associated with a change in frequency of stool, associated with a change in form of the stool. So IBS is divided to 4 types, whether if it's constipation predominant, diarrhea predominant, mixed, or unclassified. And you can use the Bristol stool chart for that. For the management, it follows the same principle as the other functional GI disorder, and we talked about this: reassure, validate, educate, and then you can use individual management plan, individualized management plan involving diet, involving behavioral therapy, and sometimes medical. So I'm not gonna repeat that here, but there are some of the non-pharmacological treatment or some dietary modification has some evidence in children for treating IBS, such as peppermint oil. Also, the low FODMAP diet has some evidence in this disorder. Functional abdominal pain not otherwise specified. So true or false, it always requires imaging and lab tests for diagnosis. By definition, it's abdominal pain at least 4 days per month for at least 2 months, not related to eating or stooling, no evidence of another GI disorders, and doesn't meet criteria for other functional abdominal pain disorders like IBS, functional dyspepsia, or abdominal migraine. It's very common in school-aged children. Usually the pain is midline or periumbilical and vague, unrelated to meals or defecations, as all the functional disorders, normal growth, lab, and physical exam, often associated with stress, school issue, or perfectionism, or children with this personality trait. So it accounts for 10% of children, diagnosis of exclusion only after very good history with no red flag and exam. As all functional disorder focus on improving daily function, not in eliminating all pain. The management of functional abdominal pain follows again the same principles of management, but I just wanna focus on one point here. Those children often miss school, and they would come to the doctor for a doctor not to miss school because of the pain, and they shouldn't do that, because when they miss school, they will get more attention because of the pain. They will get more attention. They will be free from responsibility, and all of that reinforce the pain, like the secondary gain. So it's become a cycle, and you need to break the cycle of pain and disability and focus on functioning, not relieving pain. So they shouldn't miss school because of the pain. This table here differentiates between the three types: IBS, functional abdominal pain not otherwise specified, and functional constipation. All of them present with abdominal pain, but there are differences. So IBS, usually the abdominal pain is recurrent and associated with change in bowel habit related to defecation, and usually it improves or it worsens with defecation, and you have constipation or diarrhea or both. For the functional abdominal pain not otherwise specified, usually the abdominal pain is periumbilical and not related to meals or defecation, and there isn't any change in bowel habit. For the functional constipation, they can present with abdominal pain, although the main symptoms is infrequent and hard painful stool, but they can present with pain that get relieved by defecation. And the main symptoms is the constipation and the withholding behavior. For the diagnostic duration, you need at least 3 months for the IBS, at least 2 months for the not otherwise specified, and at least 1 month for the functional constipation. For the age group, all of them start from school age and older, but functional constipation start in toddlers and all continue for the preschool and school age. And IBS are more common in adolescent. For the pathophysiology focus, IBS, from the symptoms, that is the problem in visceral hypersensitivity, gut and brain interaction, while the functional abdominal pain not otherwise specified, a problem in the central pain processing, and the functional constipation in colon dysmotility and withholding behavior. So last but not least, I'm going to give you some communication tips when speaking to parents or children. It's very important how you communicate these disorders to them. Everything is normal. Don't say that, because it could be frustrating. They're having difficulty with their symptoms, and you're saying everything is normal. But say this is a real uncommon condition with good treatments. Say, I believe you. Validate them first, and then start to explain. Don't dismiss or minimize symptoms. Don't say you just need to eat more fibers, but say, let's make a plan that includes healthy routine, diet strategies to manage stress, etc. The home take message: functional GI disorders are real and common disorders. The diagnosis is clinical. Red flags help rule out organic causes. Reassurance on functional focus in management is a key. So in the discussion board, please answer this question. What would you say to a parent who says, but she's still in pain. Are you sure you're not missing something? Thank you for listening. And if you have any question, you can always reach out to me. Thank you.